Hello, it's Riyadh, and welcome back to the Internal Medicine Review Questions, Cardiology ITE basically questions. And the question was talking about management of cardiogenic shock and when we can use intra-aortic balloon pump. This is basically the question was the indications of using IABP. So, and before that, we have to know this cardiogenic shock question. So guys, it's shock, so it's hypoxia. And for hypoxia, that's mean you have problem with the oxygen. So you have to give the patient oxygen first, because if this cardiogenic shock, so the oxygen is not enough. So basically ventilation. Okay. So what I did the above is the general measure. So for hypoxia, oxygen, for hypotension, fluid, this is just a general measure. And you have a clot, basically. There is a clot which is due to the ST elevation or I or MI. So you have three problems: hypoxia treated by oxygen as a general measure, hypotension treated by fluid, and the clot treated by aspirin, heparin, glycoprotein 2B3A. Now this is just general stuff. Now we will go down for hypoxia, as I said, ventilation. For hypotension, and this was the question. For hypotension, if the systolic blood pressure less than 90, decrease in cardiac output, hemodynamic unstable, means tachycardia. So in this case, you will not, there is no, in literature, there is no basically routine IAB. Usually they use first vasopressor. And when we said vasopressor, either you can use norepinephrine, dopamine. The effective of norepinephrine or dopamine, both of them have the same effect. However, dopamine usually have adverse effect like arrhythmia, and the problem with arrhythmia or sudden cardiac death within the next 28 days. Usually they found the cardiac death within the next 28 days, I mean in the long term, with dopamine more than norepinephrine. That's why usually they prefer norepi. Okay, they prefer norepinephrine. Now you give a patient norepinephrine and still the patient have hypotension, systolic blood pressure less than 90. This is now an indication for IABP, and usually this is a class 1. This is usually class 1 indication. So the class 1 indication, I just rewrite it another way. The class 1 indication is basically systolic blood pressure less than 90 does not respond to vasopressors, plus decrease in cardiac output. Or also class 1 indication, cardiogenic shock, which is basically cardiogenic shock, not quickly reversed by pharmacological therapy, right? Is basically the main indication of using intra-aortic balloon pump. Now, you treat it with IABP, and then the patient is stabilized. Once the patient is stabilized, now you'll go with angiography and now revascularization. So you'll say angiography and revascularization is the specific measure for a clot treatment. So you have a kind of specific measures, which is basically for hypotension, vasopressor, intra-aortic balloon pump. For a clot, usually angiography, I mean revascularization, and hypoxia is ventilation. Okay. There is a class 2, basically. All of these usually class 2 treatment of cardiogenic shock, indication of intra-aortic balloon pump. There is a class 2 indication, not in case of shock, but I think there is a time to talk about that. Not a case of shock. When the patient have refractory VT, it's a kind of weird, but it's a refractory VT in an attempt to decrease myocardial ischemia. Okay, so you can also use it. You can use it. Also, it is not category. It's not class 1. It's class 2. So if the patient have refractory VT to decrease the myocardial ischemia, there is also a kind of indication for intra-aortic balloon pump. How about refractory PE? How about refractory pulmonary edema? So it's pulmonary edema, and it's refractory pulmonary edema. There is no indications for intra-aortic balloon pump in this case. So again, no indication for intra-aortic balloon pump in pulmonary edema if it is refractory, I mean, and is usually class 3 indication, class 3, recommendation. So don't use it in refractory pulmonary edema according to this new guidelines, according to this circulation 2004. And then for the VT, if it is refractory, there is a kind of useful if you increase, but absolute indications or maybe strong indications, as we said, in cardiogenic shock, hypotension, or cardiogenic shock not quickly resolved by pharmacological therapy. Okay, thank you.